The broadcast is now starting. All attendees are in listen-only mode.
Wow. That was some pretty powerful music by Gloria Estefan, and as a matter of fact, she's one of my favorite singers and one of my favorite songs. And today, we are going to take her advice and try to reach a little higher, because today we're going to do something that we've never done before, and it's kind of like an experiment. And of course, you don't have to participate in it like COVID lab rats, but you do have to understand something about a test if you are going to take it, called the USMLE Step 1. Whoops. We're going to attack it today in a way that it's never been attacked before. But first, we're going to finish off our tremendously long journey of 11 webinars. Today's our 11th and final webinar on what we called the GU system. That included upper and lower urinary tract, male genital system, female genital system, ovary, breast, placenta, and a big lab which we did 2 days ago. But now we're going to finish it up maybe just in the first hour with breast lab, breast virtual histopathology lab. Okay, I may talk a little bit longer now than I usually do before, otherwise I'd start right away. But in the first half, we're going to look at all these slides briefly, a minute or so, and talk about the salient features of the breast and the tumors and the malignant tumors, which are the number one malignancy in women. Okay, that's pretty simple and easy and actually fun too. But I have to try to explain something briefly about what we're going to do in the second half. Because I've never done it before purely online. I used to do it regularly when I taught in the auditorium at the American Medical School in Puerto Rico, American approved medical school. And we called it the choo-choo train, but I think we could call it the USMLE Step 1 attack. Now, here's why we're going to do this. I'm sure that many, hopefully very many of you, just want to learn pathology, but I know that's not the case. I all know you are embarking on medical careers, and probably the majority, or if not many of you at least, are in medical school, and maybe you want this or need this, or maybe you heard that it's pretty good. Well, my course, which is now in its 12th year, has been designed to help second year medical students, which I myself was once, and I want to share it. I do it free, and I do it because it's fun, and I do it because I'm sort of retired at this old age of 74, and I really don't want to screw around in medical schools or dance in auditoriums anymore. I'm getting kind of old, so I just want to sit in my rocker chair here and tell you about the things I've been telling you at an American Improved, USMLE certified medical school. Okay. The people who take the USMLE Step 1 exam, which basically used to be called Part 1 or Basic Science or the first 2 years of medical schools, depended a lot on classroom, and it still does. I do surveys every now and then, and the students say that probably 95+% of the material that was on their most important and most difficult exam, Step 1, was from the classroom. And now I think I figured out a way to do something better than the classroom. We do it with high quality movies and videos and webinars online. Now, maybe some of you are afraid of it already. Maybe some of you have bought a lot of these little books that say that we are high yield. Well, you know, maybe they are, or maybe it's bullshit. But anyway, almost all of the USMLE Step 1 questions start out with clinical scenarios, something I call CCPP, the Classical Clinical patient education. So every single disease that we've discussed here will start out with a classical presentation, straightforward, not too tricky, as a matter of fact. However, please listen to this part. In order to get the clinical scenario understood well, in other words, in order to get the question correct, you have to know something, a bit of information, which I cover pretty much, or I think I do, but there are a few things I'm surprised about. They're not too tricky. So this little piece of information that you need to know to get the question right, I call a factoid. So if you know a certain factoid, like let's say choriocarcinomas secrete HCG. Okay, maybe that's easy, maybe that's hard, I don't know. In order to get it right, you have to know that factoid, and then you get the whole question right. Now, many medical schools, an increasing number of medical schools, don't really give their own exams anymore. They subscribe to the USMLE questions database, which they give the schools. And so then the professors take those questions and they put them on their test. Now that's pretty good because it helps the professors to be more geared to the licensing exam. Okay? But it's always top secret. They make us sign pieces of paper saying, we won't reveal these questions to anybody except on the exam. And why did they do that? I'll tell you why they do that. Because these are the actual exam questions. And they don't want us blabbing about them all over the place. We get to select them. Somebody watches us while we select them. We put them on our exam. And then we give the test. And what I've been doing for many years now is actually making sure that these USMLE questions are incorporated into my lecture series. Now, if they give us the exam questions late, like after we've done the lectures, then we're screwed, you know. But if they give it to us early, we could then gear our course more towards the exam that you're going to take. Now, please remember one thing. I'm not a USMLE pimp, okay? I'm not a prostitute for a government agency. What I am is a pathologist, and I want to teach you pathology. Now, I know that sounds crazy because many students, most medical students, don't want to learn pathology or anatomy. They want to just pass the fucking exam, okay? So, in a way, I am like a USMLE coach. So, we're going to take 35 questions, okay? 35 PowerPoint slides. I had like 447 PowerPoint slides, and 35 of those had the factoids on the choo-choo train. So we're going to review those factoids. Now, that doesn't mean I'm going to be giving you USMLE questions, but I want you to understand the type of mentality that those sadistic bastards have at the USMLE. In other words, if we go through all 35 of these questions, most of which I've talked about already, and you say, oh yeah, I know that, that's common knowledge, then you're going to do really well on the exam. If we review these 35 factoids, and you say, shit, I don't ever remember hearing about that stuff, then you're really should worry, okay? So that's what we're going to do. We're going to go in the second half, after the breast lab, we're going to go and review 35 factoids out of about 447 slides. And that's what I used to call riding the choo-choo train. And we did that at the medical school. The students loved it. I got 100% attendance for those sessions, rather than, 10% attendance. So it's really, really a good thing to do. And if you want to do it, you're going to have fun. If you don't like the USC or you're not going to take the exam, then, you don't have to be here. But I'm going to show you today the level of understanding that you should have to know to pass this most important exam that you'll ever take in your life. And it's also the hardest. It has the highest failure rate of all the 3-step exams. So if you pass the USMLE Step 1 well, you never, ever, ever have to worry about Step 2 or Step 3. Okay, let's close it off, and I hope I explained it, and I'll also mention it a little bit after the halftime, but let's get going first with our breast lab. So here's our slide box. And we got what? 1, 2, 3, 4. I've got 16 slides we're going to talk about in the first hour. And I numbered them because I want to present these glass slides in an orderly, logical fashion. We're going to start out at some normals, and then we're going to end at some of the nasty cancers. Okay, we're going to look at all of the crazy things in between. So I guess we could say that this is a good place to start, the one I called 1, and then normal 1. There's going to be 3 or 4 different types of normal breasts from a microscopic point of view under our microscope. And this is going to be the first classical one. Okay, how about if I ask you the question now? Anybody who would like to help me, please, just tell me by putting your answer into the question mark. Can you see this microscopic slide? That's my question. I need to hear a yes or a no. Okay? I'm hoping for some yeses. Okay, good. Now this is a breast. It's almost like any breast you'll ever see in your life. It has 2 things. It has this pink stroma, connective tissue. It has fat. Some of them have a really lot of fat. These are these white lobules, these white areas, I'm sorry. And then we have what they call the lobules of the breast. There's probably about 50 lobules inside of this breast. And these more bigger open things are the ducts, and the ducts ultimately lead into the intralobular ducts, and these are all lobules. Now, I would say this is probably about the most normal looking breast you'll see, and probably the lady may have been postmenopausal. And why do I say that? I say that because there's an awful lot of stroma or connective tissue compared to the glands. If she was young, if she was pregnant, if she was lactating, there would probably be possibly even more glands or lobules than there is connective tissue. But this one is what we would look at every day, because when a woman has her breast biopsied, chances are she's probably not too young, okay? And there's also a good chance she's postmenopausal. So, we got lobules. Let's take a look at a lobule, okay? Let's take a look at any lobule. How about this one? You can see you got your acini within the lobule. This lobule has what cross-section through maybe, 30 or 40 acini. And you got a bigger thing that looks like a duct. It looks like it's right outside the lobule, but it could be coming in from an intralobular duct. And you can see in these classical acini, or alveoli, if you want to call them, you have both epithelial cells, or mostly epithelial cells, and then these smaller cells, like you see here and here and probably here and probably here, what they call the myoepithelial cells. Okay, that's normal histology of a breast. It's a woman, there's a little bit of secretion. She may be premenopausal, but with all of this connective tissue, I can tell you she's probably not too young. Now, if she was under the influence of a lot of estrogen, these would probably be more lobules and glands within this breast biopsy, rather than maybe 20 or 30% of the cross-sectional area. Maybe you'd see 50 or 60. Okay, blink your eyes and pretend your brain is your iPhone camera. And now we're going to go to another type of normal breast. And that'll be something I called normal 2. Hey, it kind of looks like the other one, doesn't it? You got maybe a little more fat, these little white spaces, you got less connective tissue than we had on the other one, and you have more and perhaps bigger lobules. I say this woman probably has a higher estrogen level than the last slide that we saw. The lobules are bigger, but they're not really big, so I would say she's probably not pregnant or lactating, but this is a woman that has a little bit more of a gland to connective tissue ratio. Up here it's about 50-50, okay? And there's a duct over here, and there's a duct over here, and there's a interlobular duct over here. And we could take a look at the ducts if we want, or maybe we could even look at this because it has both a good-sized duct and a lot of little acini or alveoli at the periphery of the lobule. So let's just take a little peek again and see what we want to say about it. There's a duct. Here's a maybe 20 or 30 acini around it. The acini have the epithelial cells. And you know what? I'm going to try to find a classical myoepithelial cell for you also, because sometimes they're hard to differentiate from the epithelial cells. There's a myoepithelial cell right there. There's probably one over there. So you know that these are nice normal alveoli. Now, can I ask you a question? Let's say that you saw a little gland, but it had no myoepithelial cell around it. And let's say it wasn't part of a lobule, but it was actually just kind of a stray within the stroma. Then you might be worried that maybe this was cancer. But folks, once again, this is about the most normal lobule you'll ever see in a premenopausal woman that's probably not pregnant or lactating. Okay, now let's go to slide number 3. I called it NL also, but active. So maybe this one even has more density of lobules compared to the connective tissue. Let's see. Well, there's certainly a good amount of connective tissue, but look at this. This is really cool. Look at how more big and juicy these lobules are. They still have a lobular configuration. They have a duct between the lobules. Okay, this is probably more of what we call an active breast. Okay, this woman probably has more of an estrogen effect than the other two we saw. Because you know that estrogen nourishes and develops and differentiates and multiplies and cell divides these lobules, the biopsies that have more lobular density probably have more estrogen level, which is why the premenopausal ones are, let's say, juicier, if you want to use that word, than the postmenopausal ones. And while most women that have breast biopsies, in my experience, are not really young and they're not pregnant, they're most probably at least 50% postmenopausal because they're worried about a mass or some type of finding. You want to go a little bit bigger just so we could say we zoomed in on high power? There we go. There's a interlobular duct. Here's a big lobule that has acini. And here, I'll tell you right now, even though we're not getting into the cancers yet, most of the cancers of the breast do not arise from the lobules. They arise from the ducts. So most of the cancers of the breast are ductal, intraductal, and infiltrating ductal carcinomas. They do have lobular carcinomas as well, and they have their own special features, but they're not as common as the ductal. So when a woman says she has breast cancer, most likely it's have been a ductal cancer. Good, we're moving along pretty nice. This one doesn't, this one does say NL. And you're going to really like this one because it says LAC after it. Hey, just out of curiosity, can I ask you, can you read the LAC that the arrow is pointing to? I need to know that answer right now. because if you can, then you're going to be able to appreciate the fine details of the microscopic slide as well. Okay, I have a couple yeses, but I think that was from my previous question. So I'm hoping I can get another yes soon, which I'll keep looking at. So this one is called normal, but LAC. Okay. Oh my God, it's almost all lobules. There's hardly any connective tissue at all. So this woman is not only under a high influence of estrogen, but she's probably pregnant. And in addition, whenever you get a breast biopsy that's almost 100% glandular, perhaps even almost looking like thyroid gland, because there's so much secretion in all of the lobules, you could probably say this is a breast of a lactating woman. And look at all that milk, and look at, there's hardly even that much connective tissue between the lobules. But it still has a lobular configuration, doesn't it? Okay, and there's a duct, and there's a duct, and there's a duct. And probably, 95% of the cross-sectional area are lobules, rather than 50% or 30% like you might see in a younger or non-pregnant woman. Okay, we're going to say exit, and we're moving a 1. Next slide. I called FA. In fact, we have a FA1 and an FA2. Now, what do you think that might stand for? It stands for the most common solid tumor in a young woman's breast. You probably know what that is already, but this is a fibroadenoma. Okay, and the reason why it's called fibroadenoma is, first of all, it's a tumor. You can see it's well differentiated, well separated. You might even call this kind of a fibrous capsule from the surrounding breast tissue. Now, here's a little bit of surrounding breast tissue over here. And when I actually zoom in on that, you can see once again, we got a lobule, we got a lobule, we got a lobule, we got a lobule. But then you have an area here that is delineated from these lobules, and they do not follow a lobular configuration. But you have two components. The chief component is fibrous or connective tissue. That's the fibro part. And then we have little glands which do not form lobules, and that's the adenoma part. So this is a fibroadenoma. I'm going to show it to you in low power again. It's probably one of the most classical ones you see. You can see it's mostly fibrous or rubbery. And, if you have actually seen one of these at surgery or in the pathology lab, it has the perfect consistency of a super ball. And I'm going to tell you a secret, and I hope you don't tell anybody else. But most pathologists I know, including myself, have probably bounced one of these on the floor at one time or another in their life, just to confirm the fact that it does have the consistency of a super ball. Why is it benign? Because there's no malignant appearance to the glands, and also because look how sharply delineated it is from the surrounding breast connective tissue. We're going to show you another FA coming up now too. Here it is. FA2 it's called. Looks pretty much the same as the other one, doesn't it? Only in this case, you don't have much breast tissue around it. You just have kind of a fibrous capsule or pseudo-capsule. And once again, it has mostly, 80% fibrous tissue, and then a lot of these little sort of irregular adenal or glandular parts. But even if you were to look at an area like this, and you were feeling malignant one day, and you could say, hey, could these cells be cancer? Remember, if you look at the big picture, this whole thing, once again, is a sharp, very well defined tumor. Now, knowing that, you might not even want to look at these glands, but let's look at them anyway. So here we go. Let's take a look at these glands, which you might have been worrying about. You could see they're orderly. All the nuclei are kind of palisaded with each other. They don't merge into another one. They don't invade lymphatics or blood vessels. This is a fibroadenoma. Now, fibroadenomas, they're benign, they never turn malignant, but it's usually very worrisome to a woman, especially a young woman who can actually feel it or see a well-defined mass on mammography. But if you were not to do anything about it, if you were 100% sure of the diagnosis, if you did not want to do anything about it, eventually with age, these would become more fibrotic and even calcify. So when you have an elderly woman that has a very well, densely calcified, well delineated nodule, most likely it's a fibroadenoma that she's had all her life. Now, is this one older than the previous one? I would say probably yes, because take a look at the fibrous tissue. It's more dense, it's more red. Whereas in the previous fibroadenoma that we saw, which is going to be right here, the connective tissue was not as fibrous. It was more loose. Yeah, maybe there's some more fibroblasts, in this area that looks pinker, but for the most part, the stroma is not as dense or fibrotic as the one that we just saw. Okay, so 2 fibroadenomas, most common tumor in a young woman, and now we're going to go to something called IDP. Now, what do you think IDP can stand for? I don't know. IDP. Well, are you worried? Maybe not, because whatever this bluish glandular structure is here, once again, look how extremely sharply delineated it is. In fact, what if I told you that this whole circular thing is a large duct? Now you can say, well, why would a breast duct be so large? Well, maybe there's something growing inside of it that has dilated it. Okay, well, how about if we see what it might be? Well, the first thing you'll notice, even before you start to scratch your brain about benign or malignant, the first thing you'll notice is that it has a papillary configuration, is that all of these little structures look like little thumbs or fingers coming out and branching, like a tree. So this is a papillary tumor within a duct, very, very well constrained by the boundaries of the duct. And I'll tell you what, let's be a wise guy and even look closer. Look at how nice and palisaded these cells are. And look how in the center you have a little bit of fibrous tissue and a blood vessel as well, like all papilla do. Look at, here's probably even a better one over here. Here's what they call your fibrovascular core, because it has fibrous tissue and maybe some blood vessels, which you can't see too well here. And then it has a nice orderly lining of, so this is benign, it's papillary, it's very, very sharply delineated. And here, I'll show you again. Let's take a look at its boundaries, like over here, rather than just make you believe it's sharply delineated. Look how this tumor does not involve the wall of this big duct. It doesn't invade it. Another reason why it's benign, other than looking at the nuclei themselves. So this is a common benign tumor of the breast. It's called an intraductal papilloma. When we gave the lecture, we showed you a small one. This one's a larger one. This one can even be palpable. They're benign. Now, can I give you I shouldn't tell you this, but I'll give you a tip anyway. Sometimes when these papillomas are, especially superficial ones, they can have a lot of atypia in the nucleus. And I know during my long lifetime, two pathologists at different hospitals in different states calling them cancer. Well, the next day, after the frozen section was done, and they got the better quality slides, they realized they were benign. So they both lost lawsuits. So the rule of the papillomas is, according to the Bible of breast pathology by an author named Hagenson, the rule of breast pathology is never diagnose a papillary lesion as malignant on a frozen section. They violated that law and they lost a lot of money, or at least their insurance company says. So this is a benign intraductal papilloma. I'll let you peek at it again for a second before we move on to the next case. There you go. And the next case is something that I called, number 8th slide, is something I called epith-hype. Well, you think that's short for epithelial hyperplasia? And do you think that hyperplasia is basically a benign process? So I'm probably going to show you another benign breast lesion. So far, all of the abnormalities we saw, like the fibroadenoma and the papilloma, they could be masses that were palpated. However, in many breast biopsies, you may not have a mass, but you just may have an area that shows an increased number of cells without necessarily forming a mass. Like here, you already know this breast has a lot of fibrous tissue, but 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 20 or 30 lobules. Looks pretty nice. But then there's an area here towards the bottom of the slide in which you're wondering if there's an increased number of epithelial cells. So let's investigate. Yeah, this looks like it's part of a lobule, and so does this, but it looks like there's an increased number of these cells, epithelial cells, and they're not even necessarily forming a lobular configuration. Okay, they're increased. So what does an increased number of normal looking cells called? Well, it's called hyperplasia, isn't it? Now, if you're saying, well, how do you know that's not cancer? Well, I'll tell you, it might fool a lot of people, even some pathologists perhaps. However, if you actually look at these increased cells on a higher power, they still sort of conform to sort of a lobular configuration, even though they're compressed and hyperplastic. But look, they still have myoepithelial cells, these little thin cells at the periphery of the acinus. So this was diagnosed as a benign lesion. Now, from your experience, you're going to have to take that on faith, because all I could say is that for inexperienced people, you might be worried because of the presence of a large number of cells. But look, every one of these little alveoli, or acini, so to speak, is surrounded by a nice little cluster of connective tissue. It doesn't invade anything, and it still has myoepithelial cells like a normal benign alveolus should. Okay, let's go back to low power and once again show you that there's really nothing to worry about. Okay, it's not invading into this fibrous tissue. And let's also take a look at a normal breast lobule again, just in case you forgot. But once again, here's a couple of breast lobules. 1, 2, maybe part of a third one. One up here. Here's a duct. This is a interlobular duct because it's between the lobules. But if you actually look within the lobule, you may see smaller intralobular ducts. World's most normal benign breast lobule. right here. Okay, exit. And now we're going to go to something I called fat neck. Now, that doesn't mean it has a fat neck like I do, especially when I wear this nice, comfortable, sort of a turtleneck sweatshirt. This is going to be something called fat necrosis. Well, what is fat necrosis? Fat necrosis is necrosis of fat. You might not believe right away this is breast because you don't really see lobules. Oh, maybe you might see a couple up here. But what you're seeing are fibrous tissue and fat, and then something like this, these little clusters of cells that looks like they have clear spaces, and maybe they're clear because it's fat. Just like up here, this is fat. But maybe these clear spaces here are also due to fat. So let's investigate. What do we actually have here? Well, you have fibrous tissue. You have part of a breast duct over there. And then, oh my God, you see a lot of these cells, 1, 2, 3, 4, 5, 6. You see many of these cells are cells that have a granular, refractile, orangish kind of red cytoplasm. They looked exactly like pigmented hemosiderin macrophages. In fact, that's exactly what they are. They're hemosiderin macrophages. Now, why would you have hemosiderin macrophages? Well, maybe this breast tissue has been traumatized and there's been some hemorrhage, and as always, eventually these macrophages will come, like you see all along here, and start to chew up the hemosiderin. But what are these clusters of cells also? Well, these clusters of cells are giant cells because they look pretty big, don't they? And the reason why they look pretty big is because they have multiple nuclei within their cytoplasmic mass. Okay, these are multinucleated macrophages. The pathologists call them multinucleated histiocytes. And look, here's one that has hemorrhage, but these are all cells, and a lot of them have big vacuoles inside of them because these are the cells that have come in to chew up and clean up the fat and the blood pigment hemosiderin. These are the two classical features microscopically of fat necrosis. Why would fat become necrotic? Well, maybe it was traumatized. So probably the most common cause for fat necrosis is a previous surgery in which during the course of the biopsy, the surgeon has to perhaps clean up or traumatize, but not intentionally, some of the fat tissue. And look at, also because these cells are kind of densely compacted, it may be firm and it may even form kind of a mass, or it may even look like a density on a mammogram. So this is fat necrosis, traumatized fat, usually surgical, in which the macrophages either come in and individually chew up the hemosiderin like you see here, or chew up the fat and the hemosiderin like you see here. Those are the classical diagnostic features of fat necrosis. Now, slide number 10. We're progressing nicely. That one I called FB. Why would I call it FB? I called it FB because we have some kind of connective tissue here. We have fat. You don't really see any lobules. Hey, but maybe there's some lobules down here. Let's take a look. So if you see something that looks like a breast lobule, it's breast. But actually, you don't really see a lobule yet. But what you do see is fibrous tissue. And once again, these multinucleated macrophages, okay? it looks like they're forming what they call a foreign body granuloma. And why would the breast have these multinucleated macrophages? Here, I'll show you some really perfectly good examples of one. Some of them here, like here, for example, and here, and here, and here. Why would that be called a giant cell? Well, it looks like it has a giant nucleus, but when you actually look at it, not a nucleus, it's multiple nuclei within one cytoplasmic mass. And when you see a multinucleated cell sharing a common syncytial cytoplasmic mass, 9.5 times out of 10, it's a macrophage. And they could form these little granulomatous reactions. Whoops, I shouldn't have done that. They could actually form what they call these foreign body granulomas. And in this case, you don't really see much breast tissue, I'll admit that, but it was called breast, and I'll have to believe them because I don't really see any lobules. But why would you have breast, which normally has fat? You can see fat, normally has connective tissue. But why would you have a whole kind of lining of these foreign body giant cells around fibrous breast tissue? Or better yet, the question is, what is the foreign body? Well, what's the most likely foreign body in a breast? It's probably a prosthesis, right? Remember, a silicone bag filled with softer material, and this silicone acts as a foreign body, and so the capsule or the fibrous tissue of the breast forms this little foreign body layer, fibrous layer around it. And here, we're going to show it to you one more time, and probably a good place would be here. Foreign body granuloma, foreign body granuloma. If there's a lot of space within it, maybe whatever was in that material has dissolved. Maybe this was a prosthesis rupture and some of the silicone escaped, or maybe something else. But look, this is a little fibrous capsule with foreign body reaction, and I'm assuming it was a silicone bag because that's the most likely reason why there would be a layer of fibrous tissue forming around something in the breast. And here's the world's best foreign body multinucleated giant cell. And I'm going to show it to you one more time. But look at, but here's one also, and here's one also, and here's one also. Hey, guess what? I just found something new that I never saw before. This is a multinucleated macrophage, but look, it has something within the cytoplasm that looks like a star. These are called asteroid bodies, and some of the granulomas, including the foreign body granulomas, have what they call these asteroid bodies. They're most common in the granulomas of sarcoid, but if you take a look, you can see them in a lot of other places too. So you know what? I just learned something new today because I've never seen an asteroid body within a foreign body giant cell, especially one in the breast. Okay, let's move on. And here's something I called hemang. What the hell is a hemang? Well, I don't know. Would you believe me if I told you this was breast? Well, you might not believe me. You know there's a bunch of hemorrhage in the breast. You know there's a bunch of fibrous tissue. But do we have lobules? Hold on, maybe this is a lobule up here, so I could prove to you that it's really breast. Oh yeah, it's a lobule. It's like every other lobule we've ever seen. So you know this is breast tissue. And what else do you know? You know that there's a lot of hemorrhage, and there's little clusters of cells, some of which have a lot of hemorrhage, and it's within breast tissue, but they don't look like lobules. So here's the question. What are they? Maybe this was palpable. Maybe it was picked up on a mammogram. But you could see that many of the cells that comprise these little lumpy hemorrhagic islands, many of these cells have tiny lumens, and there's blood cells in a lot of these lumens. So maybe this is a tumor of blood vessels. Maybe this is a tumor of endothelial cells. And it actually is. It's called a hemangioma. It's a benign tumor. And if you doubted that these were endothelial cells, even though you see blood cells in many of them, if not most of the spaces, if you doubted that these are endothelial cells, you could stain it for a protein that you know endothelial cells classically make, especially benign endothelial cells. And that's called factor VIII. Remember when we talked about coagulation and everything, we said that factor VIII, one of the big places where it's made is in endothelial cells. So this is a benign hemangioma. Here's a large vascular space, but most of them are small. And in some areas, you might not see any vascular spaces or blood cells at all, so you would have to stain it to make sure that it's really an endothelial cell. And here's a cluster here, here's a cluster here, here's a big vascular space. Not only do you have blood within these in large spaces and small spaces, but perhaps there's even been some of these that have ruptured blood into the surrounding fibrous tissue. And let's see if I could verify that claim. Well, yeah, you could see there's blood, and it looks like it's not really very easily delineated. So some of this hemorrhage might eventually be picked up once again by hemosiderin macrophages, although I don't see many now. So let's see if we could find a few where you could actually see the blood pigment. No, I don't. So I'm not going to pretend like I do. But this is a classical appearance of a benign hemangioma. Now, do hemangiomas occur in the breast? Well, ladies and gentlemen, hemangiomas occur wherever there are blood vessels. And that's pretty much every millimeter of your body, isn't it? Okay, so let's quit with the jokes and move on to the next slide, which I called gyneco. Now, gynecomastia is a condition where male breast tissue is enlarged. So if you've seen a man on the beach that looks like he has boobs, but he's really a man, he probably has gynecomastia. The ultimate cause of gynecomastia, or men with big boobs, would be some type of estrogenic effect that man has. Some drugs increase the estrogenic effect. For example, like maybe you've probably heard of digitalis doing it, or marijuana. Sometimes he may have a tumor, or he may be on estrogens for other reason. You know, maybe he's a transsexual gender, one of these people. Okay, but you could see in the male breast, you have ducts, you have a lot of fibrous tissue, but what is the one thing that a man with enlarged breasts does not have? He doesn't have lobules, does he? So the estrogen has proliferated his ducts. The estrogen may have even been secondarily responsible for the increased fibrous tissue if there's increased ducts. But the one thing that the estrogen cannot do in a male is to develop lobules. Isn't that interesting? It's like the male body is saying, okay, estrogen, you can enlarge these breasts, but I'm not going to go all the way and have you develop lobules, because in gynecomastia, you have increased ducts but not increased lobules. And this is a classical, actually it's a beautiful case, isn't it? Now, could a male develop carcinoma of the breast? Yeah, he can, but it's very rare. And if you work in a pathology lab or you're a surgeon, if you see 100 women with breast cancer, you'll probably see only one man. It's very, very rare compared to female breast cancer. So, how about if we move on and go to the next slide, which I called IDC BEST. What do you think IDC stands for? How about the most common type of breast cancer, which is probably going to be 90% of your pathology reports, is going to be called infiltrating ductal carcinoma. So let's see if this is an infiltrating ductal carcinoma. Oh my God, yes it is. Do you see any normal lobules here? No. It's all tumor. There's a lot of fibrous tissue. The breast cancers are often called scarous because scarous, like the word cirrhosis, means scarring. Some people say that they evoke the production of more fibrous tissue. And some people say if you infiltrate into the connective tissue, it becomes firmer with additional fibrosis. So this is a classical infiltrating ductal carcinoma. Here's fat, here's fibrous tissue, here's the tumor. The tumor is not well defined, and look how it kind of streams off into the connective tissue. Here, but let me show you something else, because I had a hard time finding a intraductal carcinoma. Here's a duct that is filled up with cancer cells. If it was only this, you might call it intraductal carcinoma. However, look, it also streams off or infiltrates into the surroundings. These are about 20 nests of tumor cells here. Here's here, they come out to over here. So even though this was called infiltrating ductal carcinoma, there's a residual area of intraductal carcinoma. If it was only intraductal, then you have an excellent prognosis. Once it infiltrates, the prognosis could be dismal. Okay, now is there anything else we want to see on this page or on this slide? No, but how would you describe the pattern of infiltration? Well, some of it looks linear, some of them look like little nests, some of them are hardly more than individual cells. Hey, take a look at these. I'm going to show you an area where the infiltrating cells are only sometimes a nest of 2 or 3 or 1 cell, like over here, for example. There's a cancer cell, there's 3, there's about 3 or 4, there's 3, that's probably 1. Okay, this is very, very nasty. Okay. Okay, so let's move on. This is going to be, in fact, of all the breast slides that we have shown you so far today, this is going to be the classical cancer that might be palpable, and you would see when a surgeon biopsies it, or perhaps once you would give him this diagnosis, a very easy diagnosis. He might do the mastectomy, he might take out many lymph nodes, or perhaps the only most likely lymph node where it would drain to first, which is called the sentinel lymph node. But it's all his choice. A fewer lymph nodes he takes out, the less likely that woman might have a lymphedema. Okay, so let's go to another slide. We're almost at the end. And I call this one IDC tough. Well, remember I told you that this case here was so easy even a 3rd grader can diagnose us. I called this one tough because I'll tell you, I had to look at this very hard before I was convinced it was cancer. Okay? I think you could see a lot of fibrous tissue here. I think you could see some fat. Perhaps there's even a couple of lobules left. Here, let's take a look at a lobule just to prove to you that this is breast tissue. Yeah, look, there's a lobule. That's probably part of a lobule. But I don't see as obvious of a cancer as we saw in the last slide. Now, somebody labeled this infiltrating ductal, but I think you have to look very, very hard at the fibrous tissue. Now, you know you're going to see lobules along here because we already did. But let's say that you looked over here and you said, is this an infiltrating pattern? And you know what? It is. So now, even though I told you this was a tough case, now the more I look at it, this is not a lobule. These are infiltrating nests of little glandular cells. Some of them are almost individual cells. There's a lot of fibrous tissue in between. And they do not at all conform to a lobular configuration. So yeah, this is infiltrating ductal carcinoma also. So let's go to the next one. And if you remember when we were talking about breast in lecture, in the last webinar, we said that there are some variants of infiltrating ductal carcinoma that behave, their biologic behavior is a little bit better, so they're given different names or different adjectives. And this is a infiltrating ductal carcinoma also, but you can see it looks a little bit more well defined and less wildly infiltrative as the last one we saw. But what's all this white stuff in it? Okay, hold on. So you can see here it's pretty well defined, but here are your little nests of cells. But they're surrounded by a bunch of grayish white material. It doesn't look like fat. It doesn't look like hemorrhage. This is mucin. This is an adenocarcinoma of the breast that makes mucin. So you could call it a mucinous carcinoma. But the most common name for it would be a colloid carcinoma. And it's generally more likely to be in a more elderly woman. And it's generally not probably going to spread as early or as aggressively as the other infiltrating ductals that we saw. And why is that? I don't know. But what I think is that if these tumor cells are differentiated enough to make mucin, then they're probably going to behave in a more civilized fashion, even though they are cancer. So this is a colloid carcinoma, also an infiltrating ductal carcinoma. Remember, we told you that another type of less aggressive infiltrating ductal carcinoma was called a medullary carcinoma. Remember, we also told you that there's a tubular carcinoma that has a much better behavior. And if it has a much better behavior, it may be a little bit more difficult to diagnose because they might not look so wild. So we'll call that a day. And let's look at the last slide before we take our halftime break. And this one's going to be kind of a surprise one. I called this one PD. And there's probably not a single person out there that knows why I called it PD. Now, all of the breast carcinomas that in tumors we've seen have been of the breast tissue itself. But do you remember that the breast also has a part known as the skin? Do you also remember that part of the skin is called nipple or areola, the pigmented part? So this particular disease is called Paget's disease of the skin of the breast, of the nipple or areolar area. Now, you may have heard of Paget's disease of bone. That has nothing to do with this disease. This is a different Paget's disease. It may have been the same doctor that it was named after, but it's a different disease because Paget's disease of bone is of bone. And this disease is classically in the skin of the nipple area or areolar area of the breast. So let's start out at the bottom here where the epidermis looks pretty normal. And let's do it. You say, oh my God, this is normal skin. Why the hell are you showing us this? We have epidermis, we have the basal cell layer, we have the acanthocytes, okay, or what you're going to call prickle cell layer, and then you have the granular cell layer, and then you have a stratum corneum, and then you have the looser connective tissue that interdigitates with these little papilla called the papillary dermis, and then deeper down you have a denser type of dermis known as the reticular dermis. Okay, this is textbook classical normal skin. It just happens to be the part of the skin that covers the breast tissue. Okay, well, let's keep driving and try to figure out why I'm showing you this case. Normal skin, normal skin, normal skin. However, some of the cells in the papillary pegs, or what they call the rete pegs of the epidermis, are looking a little bit funny. They have a more of a cytoplasm. They have more atypia. Some of them are bigger and darker. And right now, and also now there's even some kind of inflammatory reaction that's being evoked at the base of this epidermis. Look, a bunch of lymphocytes here. Now, I think I have to tell you a story at this point. My professor that I dedicated this course to is named Martin Swerdlow, and I can clearly remember him saying, "I have never seen a malignant melanoma of the nipple or the areola." Why? Because it's already pigmented, and you don't get malignant melanomas usually of pigmented skinned people. However, these cells here almost look like they could be an early melanoma, but they're not. This Paget's disease is regarded as an in situ malignancy of the epidermis, and as you can see, more specifically in the deeper layers of the epidermis. So I'm going to blow this up, and I'm going to show you 3 or 4 cells that are going to scare the hell out of you. That one looks malignant. That one looks malignant. The funny mitosis, the funny prophase, big cells, multiple nucleoli, almost looking like melanomas. Now, why do these look like malignant cells? Because they are malignant cells. So, but because the dermal epidermal basement membrane is still pretty well delineated, you can say, is it an in situ type of carcinoma? Yes, it is. But you just can't normally call it squamous cell carcinoma in situ. This is a special type of in situ malignancy, which by definition does not invade, and it's not composed of breast lobules or ducts. But there's one last little thing I want to tell you about this particular tumor, Paget's disease of the breast. The thing that I want to tell you is that even though I've already convinced you that it has not, and as a rule does not invade, it is highly associated with underlying infiltrating malignancies, not only of the breast, but of other parts of the body as well. So if you do a mastectomy on this woman because a pathologist tells you it's a cancer that's limited just to the skin of the nipple, so she's cured, you think, well, statistically, there's at least a 50% chance she has a deeper cancer of some other type. Okay, that's a well-known fact. Now, are we done with the breast lab? Yes, we are, because we did all 16 slides. So let's do our break and take a deep breath. And if you want to stay around for my USMLE review, which I have not done in this course yet because I am actually opposed to being a USMLE pimp or a coach, and I would rather just teach real pathology. But I think because of my experience with USMLE, I think I kind of owe it to people who are taking the exam to give them some advice. And my advice will be, after the halftime, after our music break, is that we look at about 35 slides of the 470 slides or 450 slides, those less than 10% that we have already discussed over the last month, and tell you the types of things that you need to know because of multiple classical repetitive step one questions. I'm not pretending like I know the questions, but I can tell you the reason why they do not give these to professors who haven't taken the exam yet is because many of these questions were actually on exams, and they will be on exams repetitively. That's how lazy they are. They never make up new questions every year. They just rely on a big database. So let's close down the slide box, and maybe we'll put up the clock again, or not the guy here with the orange sweatshirt, but the actual clock. Play 3 more songs, and we'll see you in about 10 minutes.
Honey, could stay awake just to hear you breathing. Watch you smile while you are sleeping, while you're far away and dreaming. I could spend my life in this sweet surrender. I could stay lost in this moment forever. Every moment spent with you is a moment I'll treasure. Don't wanna close my eyes. I don't wanna fall asleep 'cause I miss you, baby. And I don't wanna miss a thing. 'Cause even when I dream of you, the sweetest dream will never do. I still miss you, baby. And I don't wanna miss a thing. Lying close to you, feeling your heart beating. And I'm wondering what you're dreaming, wondering if it's me you're seeing. Then I kiss your eyes and thank God we're together. And I just wanna stay with you in this moment forever, forever and ever. I don't wanna close my eyes. I don't wanna fall asleep 'cause I miss you, baby. And I don't wanna miss a thing. 'Cause even when I dream of you, the sweetest dream will never do. I still miss you, baby. And I don't wanna miss a thing. I don't wanna miss one smile. I don't wanna miss one kiss. I just wanna be with you right here with you, just like this. I just wanna hold you close. I feel your heart so close to mine, and just stay here in this moment for all the rest of time. Don't wanna close my eyes. Don't wanna fall asleep 'cause I miss you, baby. And I don't wanna miss a thing. 'Cause even when I dream of you, the sweetest dream will never do. I still miss you, baby. And I don't wanna miss a thing. I don't wanna close my eyes. I don't wanna fall asleep 'cause I miss you, baby. And I don't wanna miss a thing. 'Cause even when I dream, the sweetest dream will never do. I still miss you, baby. And I don't wanna miss a thing. I don't wanna close my eyes. I don't wanna fall asleep, yeah. I don't wanna miss a thing.
Okay, we're back, and it looks like today all of the songs will be by different classic rock and roll artists. So we got a nice mix today. And this is the second half. And this is the second half. We're going to do something I've never done before. And I think I went into great detail earlier to explain it to you, but I'll review it again. And I thought when I was taking the break here, the best way to explain it. I think it would be a fair assumption if I said that most of you here want to be a doctor. Maybe your cat was sick when you were 3 years old, so you decided you're going to be a doctor. Maybe your uncle was a doctor. Maybe you just want to be a doctor. Or maybe, like me, you don't really want to be a doctor. You don't want to play God. You just want to learn medicine and do something good for the planet, to justify your life. And I know that's part of the reason you're here. But in order to do that, you have to learn medicine. And when you learn medicine, you have to be able to dispense medicine and treatments. And in order to be allowed to dispense medicine and treatments, you have to take a licensing exam. And in the United States, where everybody seems to think there's a lot of money, there are 3 parts to a licensing exam. There's called Step 1, which is right here. I'm pointing it with my finger, and now I'm pointing to it with my computer pointer, which is the hardest one. It has a sizable failure rate, depending on a lot of things, but let's just say that it's more than a couple percent that classically fail. Okay. And then after a couple more years of medical school, where you put on your white coats and you play doctor in the clinics, you then take an exam called the Step 2, which is more clinical. Step 1 is more what they call basic science, which pathology is, and then clinical is basically when you start playing doctor for a couple of years, and then you graduate from medical school. You take at least 1 year of postgraduate medicine, and you take Step 3, which is the easiest, has the lowest flunk out rate. And then you're a doctor. You're allowed to be a pimp for big pharma and get a license, write prescriptions. Wow, isn't that cool? Okay, but the one thing you want to do in medical school is learn medicine. Don't you think that's a pretty reasonable statement? The problem is you're not allowed to learn medicine. The only reason you're there is to pass this exam. And that's different from learning medicine. And anybody will tell you that. So unfortunately, you want to be a doctor, you would love to learn medicine, but instead you have to be a slave, a pimp, a victim of the United States Medical Licensing Board. You take the exam, the U.S. Medical Licensing Exam. Step 1 is what you are all here for, theoretically. So in order to pass that exam, you have to hopefully learn medicine, but more often, in the last 10, 20, 30 years, the curriculums of various medical schools, both overseas as well as United States, have been more trying to fit in to that exam process. So basically, most people take medical school as a coaching course for this big test over here. And that's what I unfortunately had to do also. I mean, I love to teach you how diseases are and how they're formed. That's what pathologists do. But I also have a lot of tips I can offer you. Now, I know you've heard tips from other people. You've heard tips from other students that did well. You read all of these little practice question books. Well, and I would recommend you do that too. I am not a practice book professor. I'm a pathologist. I teach you pathology. But I recommend the practice books, and there's a bunch of them. USMLE World is my favorite one, but there's a bunch of others, and they all claim that they're high yield, and they have questions which are going to be like, but I'm going to give you something better today. I'm going to give you the actual USMLE questions, which have been part of their big database for many, many years, and they filter down to the professors, and then the professors use those questions. Now, all of the questions usually start out with patient presentations, even though it's a basic science exam, right? They're not going to ask you, oh, how many nucleoli are in the cell. They're going to say, a woman comes in with pain in her shoulder and she's a cigarette smoker, you know. So all of these CCPPs, classical clinical patient presentations, ultimately depend on you knowing a little piece of factual information called factoids. So what I do is I incorporate these factoids into all of my PowerPoints. But I also review the factoids. Now, these are just going to be like trivia questions. They're not going to be repetitions of my course. But if you remember, the 470 slides that we had for the genital urinary block wound up being only 35 of them had the factoids in them. So we're going to go from the first one, or actually the first one is number 18, and the last one was number 434. We're going to go through 35 questions now on my linear chain of PowerPoints, which I call the choo-choo train, and we're going to go over them. And it's not that you should write them down because they're going to be on the exam, but I want you to understand the mentality of these sadistic, self-righteous, stupid bastards that make up the questions. Okay, so we're going to drop off the video and we're going to put up the PowerPoints again. And I'm not going to whip through all 446 of them, but I'm going to stop approximately every 10 or 20 slides. Now here's the first one that we started at over a month ago. And here's a little chart I made that most of my students got A's and B's, at least on their school exam, because they understood the factoid concept. Okay, now I can't say a A and a B at a medical school is going to guarantee that you pass the step exam, but it's going to be a highly predictive event if you take courses that are USMLE geared. So I have been able to figure out how to gear my course towards learning real pathology as well as learning how to attack in a suicidal kamikaze fashion the USMLE Step 1 exam. So let's go to slide 18. Okay, these are all things which hopefully you've seen if you've been around for a month. So let's go to slide number 18, which is the first one. When we're talking about the, excuse me, autosomal dominant, or in other words, adult AD, polycystic kidney disease, we may have mentioned that it's also associated with cerebral aneurysms. So that's factoid number one. Now, you know what? When I first found that out, I didn't even know it. So I made sure that I incorporate it, or at least mention it for this choo-choo review. So that's factoid number one. Autosomal dominant polycystic kidney associated also with cerebral aneurysms. Well, you may know everything about autosomal dominant kidney disease, but you should also know it's associated with cerebral cystically dilated vascular spaces called aneurysms too. Next slide, 33. This one's an easy one. You're going to say, oh, this is a no-brainer. You should absolutely know that part of nephrotic syndrome is not only spilling out of protein into the urine, and because you spill out so much albumin or protein, your blood protein or your blood albumin becomes low. Well, that's pretty obvious, and that's an easy one. And on that one, you're probably saying, oh yeah, even I knew that in third grade. Or maybe when I show the first one, you could say, holy shit, I never knew that. So some of these are easy and some of them are hard. And this is one of the easier ones. Next, case 36. When we talked about lipoid nephrosis as one of the glomerulonephropathies, in which the primary pathology was effacement of the foot processes of the podocytes, I think I mentioned, or I'm sure I mentioned, but I'm going to emphasize it again. Lipoid nephrosis in children, most of it is in children, also called minimal change glomerulonephritis, is the most common cause of the nephrotic syndrome in young kids. In fact, I know somebody whose little brother had it. So that's factoid number, 3? Let's go to slide number 42 now. When we talked about glomerulonephropathies again, we talked about the KW, kidney chemistyle Wilson, and it was a nodular pattern of fibrosis within the glomeruli. And these little things are also PAS positive. I even think I got a picture here of a crucially important. Yeah, there's the nodule, there's the glomerulus. But you should know that that's a secondary type of glomerulonephropathy, secondary to diabetes. Okay, what else did we say? Oh, another factoid on the same slide is that Goodpasture syndrome is not only attacking the antibodies of the type 4 collagen of your glomerular basement membrane, but you also have type 4 collagen in your lung. So a classical presentation would be, a man comes in renal failure with hemoptysis. That's how the question's going to start out. But if you remember that the type 4 collagen of the lung basement membrane is the same as the type 4 collagen of the glomerular basement membrane causing the renal failure, then you can understand it. Next stop, 49 on the choo-choo train. Whoops. Let's go back to here. 43, 4, 5, 6, 7, 8, 9. Why would you see an epithelial cast in the urine on a patient with shock? It's because he's probably has tubular necrosis. So in tubular necrosis, very closely linked to shock, where there's lack of renal blood flow, those tubules are necrotic and they could be sloughed off into the urine. Okay, that's, I hope, it's kind of a logical thing. But it's not going to start out that way. It's going to start out with the classical clinical patient presentation. A woman is seen to be in shock, and you do a urine analysis, and you see that there are epithelial casts, or maybe you have to know what they look like. And if you know what they look like, you know how to get that question right. Okay, now we're going to go to what, 52. Well, we talked about the so-called ascending urinary tract infections from the enteric gram-negative bacteria. You should always know that even though you could list from microbiology Proteus, Klebsiella, Enterobacter, Strep faecalis, which are normal flora in the colon, when they get into the urinary tract, they can cause infections, both higher and lower urinary tract infections. So, when I talk about the so-called bacteria that infect the urinary tract, I always say E. coli and the boys, because E. coli is always the most likely. Okay, 61 is the next one. Okay, if you have hypercalcemia, some of that calcium is going to form crystals in and around the tubules, okay? But also, with hypercalcemia, you can get increased urinary phosphate as well. And why is that? Well, because parathyroid hormone not only mobilizes the calcium from the bone, but it also directly causes increased phosphate excretion. So how about if we make this kind of simple and maybe not even logical, but how about if you say, where the calcium goes, the phosphorus goes? Okay, that's kind of a simplistic way of looking at it, but it's very much like what we do in physiology. We say, where the sodium goes, the water goes, right? Okay, keep going now. We're going to 68. 68 is here. Oh, well, if a patient has a stenosis of his renal artery because of a big atherosclerotic plaque or even a congenital type of thing, even if it's only one kidney, because that kidney's not going to get enough blood, it's going to kick in the renin-angiotensin-aldosterone axis, Okay, so a patient comes in with a bruit, maybe because of the big renal artery stenosis. So that's going to kick up the renin to eventually increase the production of angiotensin 2, and then with the angiotensin converting enzyme to angiotensin, and then the aldosterone, which of course saves the sodium, saves the water, and increases the vascular volume, increases the blood pressure. Okay, so even if it's only one kidney, you could still get increased these compounds. And if you're lucky enough to be able to actually canalize the renal artery, you'll see it'll be really increased. 76, next stop in the choo-choo train. Oh yeah, all the different reasons for urinary obstruction. Maybe you got a stone or a tumor or a blood clot, blah, blah, blah. But another thing, which at first I didn't mention, but it should be pretty logical, is myoglobin. People that have increased myoglobin in their blood because of either damage to the skeletal muscle or crush injuries, let's say. So, you may have a patient presentation saying, oh, a woman is pulled out of an earthquake and she goes into renal failure. Well, maybe her muscles were crushed and that myoglobin got into the tubules and it blocked it. Okay, so not only was there increased muscle protein in the blood, but it got into the urine and it caused a urinary obstruction and renal failure. Okay, I hope that's logical. And I don't know if I mentioned it, but I may not have mentioned it when we did these PowerPoints before. How about if we go to number 80 and 81, because it's the same question. Renal cell carcinomas are yellow because they have a lot of fat. And of course, microscopically, when you process them, that fat becomes clear. It's yellow grossly and clear microscopically because the fat that makes that yellow also washes out when you process it with the xylene and the cells look clear. Duh. I hope that's an easy one. Next one will be number 98. We're already about a fourth done. How do you like that? The three parts of the kidney that are most likely for obstruction is where it makes the sharp turn there at the renal pelvis and the ureteral junction. It's a 90-degree turn. But then where it passes over the pelvic brim is another, or rim sometimes they call it, is another area, and right when it goes into the bladder. These are the three most likely areas for obstruction if there's a stone or a blood clot or a sloughed papilla or something. And also you should know that when there is reflux of urine, which is not sterile, into the ureter, which should be sterile, it usually occurs when there's increased pressure in the bladder, like when you're peeing, okay? So most vesico-ureteral reflux occurs when there's increased pressure in the bladder. Duh, easy one. Okay, what are we at now? 111. You're almost certainly going to get a picture on your exam in which you see IVP, where they put dye into the kidney and then it filters out into the urine. They put dye into the blood. There's a phase where you could see it in the kidney, then you could see it draining. So at some point in time, it's not going to be symmetrical. So you have to say which kidney is obstructive and where is the obstruction. Well, the obstruction is where the big bolus of urine stops, and that's would be. So if this was, for example, a left kidney, the obstruction here would probably be, in the upper half of the left ureter. It's strictly a gravity type of question, okay? Let's go to 122. Whoops, how come it stopped? Probably because, there you go. We already said this before. Vesicular reflux, if a person has a large prostate and there's a urinary bladder outlet obstruction, then you have increased pressure in that bladder when the guy tries to pee, and that's most likely when it's going to reflux back into the ureter. That should be a no-brainer as well, and that's what the USMLE expects you to know, even though They're not going to ask you the question directly. They're going to say, a man comes in and he has a urinary tract infection and he notices that when he pees, there's some pain or something like that. So if you just know that one factoid, you'll get the whole clinical scenario correct. Let's go to 129. Once again, we said this before, top urinary tract bacteria, E. coli, whether it's in the bladder, whether it's in the renal pelvis, or whether it's in the ureter. How about if we go to 141 now? And we said this several times already. I didn't have to surprise you, but most of the tumors that are epithelial of the lower urinary tract, and actually it's the epithelium of the urinary tract, which is called urothelium, and histologically they're transitional cells. So let's make it easy. Most tumors of the lower urinary tract are transitional cell carcinomas. Okay, let's go to 41. Whoops. How could we have skipped that? Oh, we're already there. Let's go to 43. You should know, everybody knows cigarettes associated with all three different types of lung cancers, the small cell, the non-small cell, but it also has a high degree of correlation, with transitional cell carcinomas too. Even though smoke doesn't pass through the lower urinary tract tubes. So know that factoid. Because it's asked often. Why is it asked often? Because they're too lazy to make up new questions every year. Or maybe they can't find smart people that make up good questions. I actually made up questions for them once, and they fired me because they said my questions were too easy. Okay, so let's go to 144, 157. There you go. The two most common infectors of the urethra, male urethra, are gonococcus and chlamydia. If you have a pus coming out of the penis, and it doesn't test positive, or you can't culture a gram-negative cocci, then most likely it's chlamydia. Isn't that logical? Okay, let's keep going. How about if we go to... Whoops, what happened? 157, we did that. So 179. We're halfway done. When they describe lesions of primary syphilis, so-called chancre, the one word they always use, without fail, is non-tender. In fact, they might say non-tender ulcer. So what does that mean? It means chancres are not painful. For some reason, that's very important clinical information. So let's go to 198. Whoops. Clinically speaking, when a testicle, the spermatic cord is traumatized, squeezed, strained, and you now have torsion of the spermatic cord, and therefore torsion of the thing that's inside the spermatic cord, the spermatic artery. There's three things you should know clinically, besides the fact that it's painful. Oh, actually, that's one of them. The testicle then is higher within the scrotum. It hurts. And usually the testicles take kind of a vertical orientation. If you've examined them, you should know that. But this oval thing then becomes more horizontal. So know the 3 H's of testicular torsion. Or if you don't, just remember that these are the level of questions that they ask. This is a clinical question, okay? Even though they call them pathology questions, much of it is clinical, because pathology is supposed to be the link between basic science and clinical medicine. So let's go to 216. Uh, 216. Oh, we've already said this twice, but I think I wanted to emphasize it again, is that the clinical symptom of enlarged prostate, which could be hyperplasia or these other terms used, hypertrophy, stromal, glandular, nodular, whatever, there's a feeling of, well, first of all, we said twice already, you have reflux into the ureter during the voiding because of the increased pressure in the bladder. But even after the man pees, you could ask this, any old man, including me, anybody over the age of 70, ask him if he ever feels like, even though he's done peeing, urinating, micturating, does he still feel like the bladder is not really totally empty? Okay, that's what they call a residual volume. Okay, you could test for it in various radiologic and even nuclear medicine ways, but remember that about the clinical one of the clinical features of benign prostate enlargement. So now we go to 220. You should know, and I don't know why it put this here, you're not likely to get too many microscopic pictures on your step 1 exam. Sometimes they do. There's not as many as I would like to put, but when you should know that one of the features of perineural invasion is not only here and here. See this lighter space here and this lighter space here. It looks like it's surrounded by glands in the space around this nerve. That's very common in many of the adenocarcinomas, and especially in prostate carcinoma. Okay, so let's go to 240. Whoops. Whoops, I missed it. I overshot it. When you have a carcinoma of the vulva, it usually goes to the superficial inguinal lymph nodes. Rarely it can go to the deep inguinal or internal iliac, but that's one way if you see an enlarged lymph node on CT or whatever. If it's from the vulva, they drain superficial because the vulva is superficial. It's basically external genitalial skin. But it can rarely go to the deeper lymph nodes, although it usually doesn't. That's what you should know. I don't know why, but let's go now to number, whoops, where are we? That was number, whoops, 241. Whoops, I'm sorry. Let's go to 280. So we have a long way to go now. We got skipping 40 slides. Okay, here we are at 280. 10 more buttons to press on the choo-choo train. Whoops. Here's a leiomyoma inside of a uterus. It's very logical. It could be underneath the serosa, it could be within the myometrium, or it could be what they call submucosal, which means in close proximity and even invaginating the endometrium. Well, it's the submucosal ones that are more likely to interfere with pregnancy. And sometimes if a woman has a relatively small single submucosal leiomyoma, that may greatly increase the chances of her having a normal pregnancy rather than having the endometrial cavity completely compressed by a muscle tumor and therefore interfering with implantation. Okay, how about if we go to 285 now? The more a woman is exposed to estrogen during her lifetime, like an early menarche or an early age of first birth, the more likely she is to develop adenocarcinoma of the endometrium. And also, if a woman comes in with bleeding after her menopause, where she's not supposed to bleed at all, and you don't do a DNC, you might be missing a cancer. I know a couple of guys that were sued because of this too. Okay, well that's kind of a not only a no-brainer, but that's something that was a USMLE factoid. Let's go to 3:15 and we're almost done, which is good because we're getting close to the end of the hour. 3:15 is over here. Okay. With Stein-Leventhal syndrome, we described as polycystic ovarian disease, or sometimes they say PCOS, polycystic ovarian syndrome. Their androgens, besides these women being obese and maybe don't have very much by way of periods, they don't ovulate, they're sterile, they're infertile. They also can have elevated estrogen, so they could have male hair features. So hirsutism is associated with Stein-Leventhal or PCOD or PCOS, depending on whatever you want to call it. Let's move on to 328. Okay, dermoid cysts are often cystic. They're benign, usually. Most common tumor in a young woman. So if that starts out with, a 25-year-old woman with a cystic ovarian mass. Okay, so even though a teratoma could have anything in it, the most common things are hair and sebaceous material. Hell, you could even have a tooth inside of it. I've seen one with a tooth. Some of them even have thyroid tissue. They could take up radioactive iodine, okay? They could have a tooth, you know. You could do an x-ray of the pelvis and you think it's a dental x-ray. But remember, they have hair and they have sebaceous material, as most of them do, as the prominent thing. In fact, this entire cyst could be filled with yellow, yucky, sebaceous material. Let's go to 342. How do you know a woman has an ectopic? Well, first of all, you know she's pregnant. So she has a positive pregnancy test, okay? Positive HCG. But she has abdominal pain. She's usually in the first trimester, and the ultrasound can usually confirm it. So this is the classical presentation clinically. So one thing that you might want to do is with all the diseases we talk about, you should also learn what their classical clinical patient presentation is. I wish somebody wrote a book with the CCPP of all diseases, and that would probably be the very, very best Step 1 USMLE study guide that's ever been made. I'm too lazy to do it myself, so let's go to 343. We're almost done. Oops, how did we skip that? Oh, there's another tubal pregnancy specimen. This one should be a no-brainer. But what you should know is that if the tube is ruptured because of the baby, either through the bleeding through the fimbriated end or perhaps even rupture of the attenuated muscular wall, this woman could have massive bleeding into her abdominal cavity, and it has a very serious prognosis. Some of them have a significant mortality. So that was number 343. Let's go to the next slide. Oh, we already did. Oh, no. One of the complications of late pregnancy, which is relatively rare, is that during delivery you could have a significant amount of amniotic fluid escape into the blood because they have large vascular spaces and a place where there's a large amount of amniotic fluid. So when you get a large amount of amniotic fluid, there's always a little, I think, but when you get a large, that could be a very serious complication. And the one way you could confirm it pathologically is that you have a woman that died of childbirth here, and you're looking at one of the arteries in her lung, and it has these little wavy, what they call squame-like cells, which you see that line the amniotic cavity. So that's one of the. I've only seen about one or two of these in my life, but they're spectacular. Okay, so let's go down to the next one, which will be only 5 more left. 350. Whoops. Oh yeah, this is a placental abnormality called placenta accreta. And remember, we said that with placenta accreta, you don't have much by way of decidua between the placental villi and the myometrium. Remember, decidua is the endometrium of pregnancy, okay? But if for some reason there's not much of it, you have direct villi going into the myometrium, and when that placenta comes out, there could be a significant amount of hemorrhage, and that could be a very serious thing as well, causing death, DIC, shock, you know, the usual reason why people might die at childbirth. 353. Oops, what's that? I think, oh yeah. This is just a terminology thing. This was an easy question. But this is the factoid that you should know, that preeclampsia is these 3 things here. But if it's severe and it results in DIC or convulsions, then it's no longer preeclampsia. That's called eclampsia. Preeclampsia is very common and does not have a high mortality or morbidity. Eclampsia does. So it's a big difference of whether you call it pre or not. And how about if we move on to the next one, which will be 5 more slides. We're almost done. How do you know a woman has a mole? Well, she's pregnant, so she has elevated HCG. And she's most likely could be in maybe the first or maybe second trimester, okay. But usually, you could hear fetal heart sounds even in earlier pregnancy. I mean, not really early, but certainly the age for a hydatid mole. But because moles are not associated with viable pregnancies, you think the woman's pregnant, positive pregnancy test, but no fetal heart sounds. That's a clinical factoid that you should know. And also, we might have mentioned pathologically is that when a fertilized egg does not have its original maternal nucleus, that's present in many moles. I'm not going to say all of them, but it's kind of like a well-known fact. 414, we only got 2 left. So let's go to 414. Skip a lot of the breast stuff here. We got a lot only 2 more slides left. Then we'll let you go home. Or if you're not here, you could watch the movie and I won't feel guilty. Okay, 414 is right here. Oh, we've already said this. We said this in lab today. We said that a fibroadenoma is a very well described rubbery nodule. It's often described as mobile. It's so well delineated from the breast tissue that it can actually move when you palpate it. It's a young woman, and that's the classical clinical patient presentation for a fibroadenoma. Young woman, well-defined nodule, and I also said it has the consistency of a super ball. I don't think you'll hear the word super ball on a USMLE exam. Last one is 434, which is very close to the end. There you go. We talked about sentinel lymph nodes today when we were in breast lab, and I think you should know about it. It's not something that's new. It's something that's been around for a long time. There are multiple ways with dyes and radiologically and isotopes. There are ways of predicting which of the axillary lymph nodes are going to be the most likely to receive a metastasis. And usually those are the ones that are closest to the tumor. So I've gone into operating rooms and I've injected lung tumors with radioactive tracers, and as soon as we see it appear in a lymph node, that lymph node can then be biopsied by the surgeon, and he doesn't have to take out 25 more, okay? So it'll have the same prognostic value as if he took out all 25, but it will greatly lessen the likelihood of disfiguring lymphedema. And that's all of the cases. And guess what? We still got 1 minute left, so I can't be accused of keeping you late. Let's play the closing song and do our usual Rock on Buzzards act at the end. So here we go, another closing song. Rock on, Buzzards.